Welcome to the topic Bronchial Asthma in the module Respiratory Medicine. By the end of this topic, you should be able to define what is bronchial asthma, discuss the causes and pathophysiology of bronchial asthma, outline the clinical features of bronchial asthma, list the investigations in the diagnosis of bronchial asthma, and discuss the principles of asthma management, indications for invasive or non-invasive ventilation. Let's get started. Asthma is a common chronic disorder of the airways that is complex and characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. The term asthma is a Greek word that is derived from the verb azein, meaning to exhale with open mouth or to pant. Asthma can be classified into atopic, which is extrinsic asthma, and this is the type of asthma that is triggered by allergens like pollen, dust mites, animal dander, or food. Intrinsic asthma is the type of asthma that is not triggered by allergens. The causes are not well understood, but this is the most severe and persistent asthma that has a later onset in life. Occupational asthma is an adult-onset asthma where patients usually come in with a history of recently being exposed to a certain airborne substance. Now let's take a look at the risk factors for this condition. They can be broadly grouped into endogenous and exogenous groups. Endogenous risk factors are conditions that occur together in relation to one another, and these are atopic rhinitis, atopic dermatitis, airway hyperresponsiveness, and genetic predisposition. Exogenous, or also known as environmental risk factors, can include indoor and outdoor allergens, occupational exposure to allergens and dust, and tobacco smoke and air pollution. Airflow limitation in asthma is recurrent and caused by a variety of changes in the airway, and these include bronchoconstriction, airway edema, airway hyperresponsiveness, and airway remodeling. So the pathophysiology is complex, and as mentioned earlier, there are three main components which involve airway inflammation, intermittent airflow obstruction, and bronchial hyperresponsiveness. Asthma is usually mediated by immunoglobulin E and precipitated by an allergen. Sensitization occurs at first exposure, producing allergen-specific IgE antibodies that attach to mast cells. When there is repeated exposure to the same allergen, these allergens will bind to the antibodies present on the surface of the mast cells, causing release of inflammatory mediators like prostaglandins, leukotrienes, and histamine, which in turn causes bronchospasm, triggering an asthma attack. If left untreated, there will be changes in mucosa due to these mediators, such as bronchoconstriction of smooth muscles, secretion of mucus, and inflammatory bronchial wall thickening. All these changes will then cause a narrowed, irregular airway as well as turbulent and poor flow. Asthma can be caused by environmental exposure to allergen, occupational sensitizer, atmospheric pollution, drugs, viral infections, cold air, emotion, irritant dust, vapor and fumes, and genetic factors. Let's take a look at occupational asthma. This is the commonest industrial lung disease with over 400 causes and accounts for up to 10% of adult-onset asthma. Episodic cough and wheeze with nocturnal symptoms are classical of occupational asthma. Patient may either present with concerns that chemicals at work are worsening their asthma, or you may notice in the history that symptoms seem better at weekends or when away from work. Exposure to the following chemicals is associated with occupational asthma, such as isocyanates, which is the commonest cause. Example occupations are spray painting and foam molding using adhesives. Next would be platinum salts, soldering flux resin, glutaraldehyde, flour, epoxy resins, and proteolytic enzymes. Serial measurements of peak expiratory flow are recommended at work and away from work. Referral should be made to a respiratory specialist for patients with suspected occupational asthma. The diagnosis of occupational asthma involves serial measurements of peak expiratory flow rate or PEFR, which are recommended both at work and away from work. Recordings should be performed 2-hourly for 4 weeks, or if this is not possible, methacholine or histamine challenges can be undertaken after days at work and away from work. Bronchial provocation testing should only be undertaken in a specialized center. The most appropriate step is firstly to review the work environment to ensure that exposure to paint fumes are minimized. If these changes do not improve patient's symptoms, then the patient should be offered alternative work or a change of job. The updated 2011 guidelines suggest dividing patients into a high, intermediate, and low probability of having asthma based on the presence or absence of typical symptoms. The new BTS guidelines take a more practical approach to diagnosing asthma. If a patient has typical symptoms of asthma, a trial of treatment is recommended. Normal spirometry when the patient is well does not exclude a diagnosis of asthma. Management is based on this assessment. High probability, you may start a trial of treatment. Low probability, you may investigate or treat other conditions. For patients with intermediate probability of asthma, further investigations are suggested. The guidelines state that spirometry is the preferred initial test, where you have FEV1 over FVC being less than 0.7, you may want to initiate trial of treatment. If the FEV1 over FVC is more than 0.7, further investigation or consider referral. Acute asthma is nearly always seen in patients who have got a history of asthma. Patients with acute severe asthma are stratified into moderate, severe, or life-threatening. In addition, a normal partial pressure of carbon dioxide in an acute asthma attack indicates exhaustion and should, therefore, be classified as life-threatening. The British Thoracic Society defines near-fatal asthma as an attack with raised partial pressure of carbon dioxide and or requiring mechanical ventilation with raised inflation pressures. A raised partial pressure of carbon dioxide is an important sign that intubation may be required if the patient is not responding to maximal medical management. Bedside investigations that you could do would be the peak flow meter, but remember this is not diagnostic, but instead it helps you identify severe exacerbations and follow-up cause of the illness in a given patient and to monitor how they respond to medications. Anything less than 70% of the patient's personal best is considered as significant airway narrowing, pointing towards an acute exacerbation. You can also do a spirometry test, and this is diagnostic of asthma. Here you will compare how much air comes out in the first second to the total volume of air blown out, which is FEV1 over FVC. Anything less than 70% indicates significant airway obstruction. The good thing about this investigation is that you may differentiate between bronchial asthma and COPD by seeing if there is significant amount of reversibility of airway obstruction following the administration of beta agonist. If there's more than 12% over 200 mL reversibility, it indicates bronchial asthma. Other tests include finding out the allergen, which could be done by a skin prick test or in vitro testing for specific IgE antibodies, such as using the radioallergosorbent assay, or fluorescent allergosorbent test, FAST, and the ELISA test. If we look at bedside test or signs, we might want to focus on the peak expiratory flow rate. Apart from that, in status asthmaticus, there are specific signs that will tell us there is imminent respiratory arrest, which include paradoxical thoracoabdominal movement, wheezing which may be absent, severe hypoxemia which may manifest as bradycardia, and pulsus paradoxus may disappear. And this finding suggests respiratory muscle fatigue. When we look at specific tests, there are important objective evaluations in these investigations. Firstly, the fractional exhaled nitric oxide. When you exhale, your breath can show if you have inflamed airways, and this test measures the amount of nitric oxide in one's breath. It helps to decide the severity of inflammation in the airways. Spirometry and reversibility testing is a test that we have discussed earlier, which tells us the severity of obstruction and the reversibility upon administration of bronchodilator therapy. And finally, allergic testing, which can be used to identify allergic factors. The British Thoracic Society guidelines recommend arterial blood gases for patients with oxygen saturations less than 92%. Histologic evaluation of airways typically reveal infiltration with inflammatory cells, narrowing of airway lumina, bronchial and bronchial epithelial denudation, and mucus plugs. As for imaging studies, a chest radiograph changes which can be seen include pulmonary hyperinflation, bronchial wall thickening, and peribronchial cuffing. A radiograph may also show evidence of parenchymal disease, atelectasis, pneumonia, congenital anomaly, or a foreign body. Now let's take a look at the management. The British Thoracic Society (BTS) classify patients with acute asthma into moderate, severe, or life-threatening categories. NICE released guidance on the management of asthma in 2017, and these followed on quickly from the 2016 British Thoracic Society guidelines. On admission, all patients with life-threatening asthma should be admitted to the hospital. Patients with features of severe acute asthma should also be admitted if they fail to respond to initial treatment. Other admission criteria include a previous near-fatal asthma attack, pregnancy, an attack occurring despite already using oral corticosteroids, and presentation at night. Patients with acute severe asthma are stratified into moderate, severe, or life-threatening asthma. When it comes to oxygen therapy, patients are given oxygen if they are hypoxemic, and it is important to start them on supplemental oxygen therapy. If patients are acutely unwell, they should be started on 15 liters of supplemental via a non-rebreather mask, which can then be titrated down to a flow rate where they are able to maintain an SpO2 of 94 to 98%. Next would be inhaled therapy. And here, high dose of short-acting beta agonist via nebulizer or spacer is given for bronchodilation with short-acting beta agonists. High-dose inhaled short-acting beta agonist examples include salbutamol or terbutaline. Nebulized anticholinergic such as ipratropium bromide is administered if there's no response to beta-2 agonist. Intravenous therapy if poor response to inhaler therapy is given, and this is in the form of magnesium sulfate with a dose of 2 grams IV over 20 minutes. IV aminophylline may be considered following consultation with senior medical staff, and this is typically reserved for patients who fail to respond and require senior critical care support. However, there is little evidence to support the use of intravenous aminophylline, although it's still mentioned in management plans. If there's still no response, then intravenous salbutamol may be considered. Endotracheal intubation and mechanical ventilation is given in the case of respiratory failure. Now let's take a look at the stepwise management of stable asthma. The first step would be with inhaled short-acting beta-2 agonists when necessary. And if this is still poorly controlled, you may then add on inhaled corticosteroids at 200 to 800 micrograms a day. 400 micrograms is an appropriate starting dose for many patients. The next step up would be adding an inhaled long-acting beta-2 agonist or LABA, for example, salmeterol or formoterol. You may want to assess the control of asthma, and if there's good response to LABA, you may continue the LABA therapy. If there's only partial response, they may still benefit from this therapy, but control is still inadequate. You may continue, however, increasing the inhaled corticosteroid dose to 800 micrograms a day if the patient is not already on this dose. If there's still no response to LABA, you may want to stop the treatment. You may want to increase inhaled corticosteroid therapy to 800 micrograms a day and institute trial of other therapies such as leukotriene receptor antagonists or slow-release theophylline. The next step would be to consider trials of increasing inhaled steroids up to 2000 micrograms a day, and this is considered high dose inhaled corticosteroids. An addition of a fourth drug, such as a leukotriene receptor antagonist, slow release theophylline, or a beta 2 agonist tablet, may be considered. And last but not least, the final step, if there's still poorly controlled status of asthma, you may use daily steroid tablets in lowest dose providing adequate control, considering other treatments to minimize the use of steroid tablets, maintaining a high dose inhaled steroids at 2000 micrograms a day, and finally to ensure that patient is referred for specialist care. In summary, bronchial asthma is a chronic syndrome of increased inflammation of the lower airways and hyperresponsiveness to a wide range of triggers. Consider risk factors for this condition, which may include endogenous, such as atopy or allergic rhinitis, and exogenous or environmental, such as occupational exposure to dust and organic material. Investigations can help with excluding other lung diseases. A reversibility test can be done following a basic spirometry once obstructive airway disease has been established. Some important pointers to take note of when it comes to management of asthma is intravenous magnesium sulfate is useful in acute severe asthma rather than COPD. The respiratory rate below 25 breaths per minute is against the need for magnesium sulfate IV in severe asthma. Current guidelines do not support the routine use of non-invasive ventilation in asthmatics as they will need high pressures. Non-invasive ventilation is not recommended in acute severe asthma. A pH less than 7.35 likely represents carbon dioxide retention in a tiring patient and is an ominous sign in acute asthma, which is the strongest indicator of a need for intubation and ventilation. And lastly, performing serial peak flows in a patient with life-threatening asthma is neither practical nor desirable. We have come to the end of this topic. Thank you.